Hello and welcome to the topic Rheumatoid Arthritis in the Rheumatology module. By the end of this topic, you should be able to define rheumatoid arthritis, outline the causes of rheumatoid arthritis, discuss the pathophysiology of this condition, describe the clinical features, lab investigations, and radiographic features, outline clear steps to make a diagnosis, discuss the complications, and explain the principles of management in adults in pregnancy. Let's get started. The term rheumatoid comes from rheumatism, which means musculoskeletal illness, and arthritis refers to joint inflammation. Rheumatoid arthritis is a chronic autoimmune disorder that primarily affects joints. It results in warm, swollen, and painful joints. It is known that this condition occurs following an interaction between genetic factors and environmental factors. Specific genetic factors that are involved are HLA-DR1 and HLA-DR4. And environmental factors that can trigger a susceptible person can include infections and even cigarette smoking. As we learn the pathophysiology of rheumatoid arthritis, let's understand the anatomy of the joint. A joint here is made up of two bones meeting each other and at their articular cartilage surface. A synovial joint is made up of a fibrous joint capsule which connects to the periosteum of the bone. Within the space of this joint area is the synovium, which is made up of synovial fluid generated by specific cells. In rheumatoid arthritis, the autoimmune process triggered by the interaction between genetic factors and the environment. Due to the genetic factors, any trigger in the environment such as an infection or cigarette smoking can lead to the formation of certain proteins through a process called citrullination. This stimulates antigen-presenting cells, which activate CD4 T helper cells. T helper cells stimulate the proliferation of plasma cells to generate antibodies. The antibodies then move to the joint and recruit more macrophages and cytokines, which together leads to proliferation of synovial cells. This then forms a pannus, which consists of granulation tissue, fibroblasts, myofibroblasts, and inflammatory cells. These cells also produce proteases which break down cartilage in the joint. As the disease progresses, angiogenesis takes place, causing the increased warmth and swelling. Common sites for pannus formation include over the cornea, over a joint surface, or on a prosthetic heart valve. In rheumatoid arthritis, inflammatory cytokines affect multiple organ systems, leading to extra-articular problems. It can affect the brain, blood vessel, forming vasculitis, skin causing rheumatoid nodules, skeletal muscles. In response to inflammatory cytokines, the liver also undergoes inflammation. The pulmonary system also ends up having complications affecting the interstitial and pleural layers. Typical features include swollen, painful joints in the hands and feet, stiffness worse in the morning lasting more than 1 hour, which gradually gets worse with larger joints becoming involved. Presentation usually is insidious and develops over a few months. The most common form of inflammatory arthritis is characterized by symmetrical arthritis of the small joints of the hands and feet and has lasted for more than 6 weeks. It typically affects the proximal interphalangeal, metacarpophalangeal, and wrist joints. The sacroiliac joint is spared in rheumatoid arthritis. Extra-articular features such as rheumatoid nodules over the extensor surfaces of tendons are involved, and there will also be vasculitic skin involvement. As for joint deformities, you'd expect to see a swan neck deformity, which is the distal interphalangeal joint hyperflexion with proximal interphalangeal joint hyperextension. Botanois deformity, which is the proximal interphalangeal joint flexion with distal interphalangeal joint hyperextension, and ulnar deviation, which is due to inflammation of the metacarpophalangeal joints, which lead to dislocation of these joints with a pool of tendons on the dislocated joints. The NICE guidelines have stated that clinical diagnosis is more important than criteria such as those defined by the American College of Rheumatology. Classification criteria for rheumatoid arthritis are as shown here. So first of all, you'd want to look at joint involvement. If there's only one large joint involved, that would be a score 0. But if there are 10 joints or more, that would be a score 5. As for serology, Negative rheumatoid factor and negative anti-CCPs give a score of 0, and high positive for these two factors would give a score 3. Acute phase reactants are also taken into consideration. If they are normal, they would give a score 0, and if it's abnormal, it would be 1. As well as the duration of symptoms being less than 6 weeks, scoring a 0, and more than 6 weeks, scoring 1. A total score of 6 and more is needed to diagnose rheumatoid arthritis. Rheumatoid arthritis typically affects the metacarpophalangeal and proximal interphalangeal joints symmetrically. Psoriatic arthritis affects the distal interphalangeal joint and tends to be asymmetrical. This table shows the differences between rheumatoid arthritis and osteoarthritis. Rheumatoid factor is a circulating antibody, usually IgM, that reacts with the Fc portion of the patient's own IgG. It is recommended as the first-line antibody test for patients with suspected rheumatoid arthritis. It can be detected by either a Rose-Weller test, which uses sheep red cell agglutination, or latex agglutination test, which is less specific. Rheumatoid factor is positive in 70 to 80% of patients with rheumatoid arthritis. High titer levels are associated with severe progressive disease, but it's not a marker of disease activity. Other conditions that are associated with positive rheumatoid factor include Feltis syndrome, Sjögren's syndrome, infective endocarditis, SLE, as well as systemic sclerosis. Anti-CCP positivity is a prognostic marker. This peptide antibody may be detectable up to 10 years before the development of rheumatoid arthritis. NICE recommends that patients with suspected rheumatoid arthritis with rheumatoid factor negative should be tested for anti-CCP antibodies. Erythrocyte sedimentation rate or C-reactive protein is seen up to 40% of patients with rheumatoid arthritis and may have normal levels. In the early stages of an insidious onset of rheumatoid arthritis, the acute phase markers are often normal, particularly when small joints are involved. A normal C-reactive protein can help to exclude the diagnosis of an inflammatory arthritis, but an elevated value is never a specific finding. As for radiographic changes, the radiographic features of rheumatoid arthritis can be remembered by the mnemonic LESS. L for loss of joint space, E for erosions, S for soft tissue swelling, and S for soft bones or osteopenia. At the early stage, the most likely investigation that will help with the diagnosis are the X-rays, particularly hands and feet X-ray. Foot joints are often radiologically affected before hand joints. Periarticular osteopenia and osteoporosis would point towards a diagnosis of rheumatoid arthritis. Loss of joint space is common in both rheumatoid arthritis and osteoarthritis, also in pseudogout. Poor prognostic features include anti-CCP antibodies, which is the poorest prognostic factor of all, rheumatoid factor positive, HLA-DR4, insidious onset, acute or sudden onset, and it's not a poor prognosis, poor functional status at presentation, X-ray showing early articular erosions, as well as extra-articular features such as nodules and the female sex. As for extra-articular complications, ocular ones are common with 25% of patients having eye problems, and these include keratoconjunctivitis sicca, which is the most common, characterized by dry, burning and gritty eyes caused by decreased tear production. Other associated symptoms include irritation, redness, discharge, and easily fatigued eyes. Blurred vision may also occur. Scarring of the cornea may occur in some cases without treatment. Next would be cardiac complications. Constrictive pericarditis is the commonest cardiac complication of rheumatoid arthritis. As for ischemic heart disease, rheumatoid arthritis carries a similar risk to type 2 diabetes mellitus. As for respiratory complications, we might expect to see pulmonary fibrosis, pleural effusion, pulmonary nodules, bronchiolitis obliterans, methotrexate pneumonitis, and pleurisy. Let's take a look at what is Feltis syndrome. Feltis syndrome is defined as the triad of rheumatoid arthritis, splenomegaly, and leukopenia. It is considered as an extra-articular manifestation of rheumatoid arthritis. It occurs more frequently in patients suffering from other extra-articular manifestations such as Sjogren's syndrome. Features include rheumatoid arthritis, leukopenia, lymphadenopathy, and splenomegaly. Leg ulcers and recurrent infections as well as episcleritis may be present as well. ANA is positive in more than 90% of patients. Pulsed corticosteroids or cyclophosphamide therapy may be effective in raising neutrophil counts, as may appropriate switching or intensification of DMARD therapy for rheumatoid arthritis. Severe disease include the use of cyclophosphamide, colony-stimulating factors to stimulate production of granulocytes, and splenectomy is usually reserved for patients with severe neutropenia and recurrent infections who fail to respond to medical intervention. Patients with evidence of joint inflammation should start a combination of disease-modifying drugs as soon as possible. Other important treatment options include analgesia and physiotherapy as well as surgery. Latest recommendation by NICE in 2018 suggests DMARD monotherapy with or without a short course of bridging prednisolone. Monitoring response is done with a combination of CRP and disease activity. Flares are often managed with corticosteroids. As for DMARDs, their examples would include methotrexate, and that's the most widely used DMARD. Monitoring of FBCs and LFTs is essential due to the risk of myelosuppression and liver cirrhosis. Other important side effects include pneumonitis, sulfasalazine, lefonamide, and hydroxychloroquine. As for TNF inhibitors, the current indication for this is an inadequate response to at least 2 DMARDs, including methotrexate. Etanercept is a recombinant human protein, acts as a decoy receptor of TNF-alpha, subcutaneously administered, and can cause demyelination. There's also a risk of reactivation of tuberculosis. Infliximab is a monoclonal antibody. It binds to the tumor necrotic factor alpha and prevents it from binding with TNF receptors. It's intravenously administered, and it carries a risk including reactivation of tuberculosis. Last but not least, adalimumab. And this is a monoclonal antibody administered subcutaneously. Next would be rituximab. This is an anti-CD20 monoclonal antibody resulting in B-cell depletion. 2 1 grams intravenous infusions are given 2 weeks apart. The infusion reactions are common. As for abatacept, this is a fusion protein that modulates a key signal required for activation of T lymphocytes. It leads to decreased T-cell proliferation and cytokine production. Given as an infusion, and it's not currently recommended by the NICE guidelines. Patients with early or poorly controlled rheumatoid arthritis should be advised to defer conception until their disease is more stable. Rheumatoid arthritis symptoms tend to improve in pregnancy but only resolve in a small minority. Patients tend to have a flare following delivery and they should be referred to an obstetric anesthetist due to the risk of atlantoaxial subluxation. Methotrexate is teratogenic and NSAIDs are given in the first trimester and it carries a risk of abortion, so they are absolutely contraindicated. Methotrexate should be stopped at least 3 months before conception. NSAIDs may be used until 32 weeks, after which it should be stopped due to the risk of early closure of ductus arteriosus. Prednisolone, sulfasalazine, and hydroxychloroquine are safe in pregnancy. Azathioprine, cyclophosphamide, methotrexate, and cyclosporine are contraindicated in breastfeeding mothers. Alright, as a quick recap, rheumatoid arthritis causes progressive symmetrical destruction of at least 3 joints, especially in the hands and feet, over more than 6 weeks. But the main mortality comes from cardiovascular disease, especially myocardial infarction and stroke. Diagnosis is generally based on joint involvement, having an elevated rheumatoid factor and anticyclic citrullinated peptide antibodies, as well as an elevated ESR and CRP. In addition, bilateral plain radiographs of the hands, wrist, and feet are generally obtained during the initial evaluation, primarily as a baseline for monitoring disease progression. The long-term management of rheumatoid arthritis is the use of non-biological DMARDs. In addition, severe cases get biological DMARDs. Treatment of acute flares can be done with NSAIDs, while more severe flares may require short-term use of glucocorticoids like prednisolone. In addition, individuals should take preventive measures for cardiovascular diseases like exercise and smoking cessation, as well as routine use of low doses of aspirin and lipid control with statins. We have come to the end of this topic. Thank you.